welcome to this public lecture today, which is really linked to the MA programme in health and social care offered here at Leeds Beckett University. I know a number of you are involved with that, and some of you are aware of it, but also very pleased to welcome others from the healthcare community here today for this lecture. One or two practical things. I had a meeting in here this morning, an editorial meeting about the Journal of Health and Social Care Chaplaincy, and the fire alarm did go off and we were evacuated onto the pavement. So I hope that won't happen again, but if we do, we just go out of those doors there and, as I've discovered, are shepherded fairly forcibly down to the left. But that's fairly straightforward. I don't think there's anything else I particularly need to say. Loos, if you do need them, just outside these doors on the right. I'm very pleased to welcome George Fitchett, who's arrived in Leeds this morning, about 9:35 from the Netherlands. The origins of the invitation for George to be here today actually go back to a rather warmer conference in California last summer in June, when I was able to attend the US chaplains' main conference, and it emerged in conversation with one of the chaplains from the Netherlands who was also there, that George had accepted an invitation to go this week to the Netherlands, and we thought, well, it isn't too far and he might be open to persuasion, and I'm delighted that you have been and that you've been able to come over for the lecture, and for those of you also staying this afternoon for the symposium on case studies. George is a professor and the Director of Research at the Department of Religion, Health and Human Values at Rush University Medical Center in Chicago. He also holds an appointment in Rush's Department of Preventative Medicine. He's been a certified chaplain and pastoral supervisor for more than 30 years, and is the author of many publications, including his recent title, co-edited with Steve Nolan. It's lovely to see Steve here, Spiritual Care in Practice, Case Studies in Healthcare Chaplaincy. And Steve has brought some copies, so if any of you have been desperate to get hold of that book, there'll be no extra charge for it being autographed and signed today. Steve wasn't looking too convinced by that, perhaps there is an extra charge. And also there's one of George's books here on spiritual assessment. Just for sake of interest, can we have prices on those?
I think George's is £10 and the other one is £18.99.
£18.99, and George's a snip at a mere £10. Since 1990, George has been involved in research examining the relationship between religion and health in a variety of places of community and clinical populations, cancer patients, rehabilitation patients, psychiatric, and also patients with diabetes. And his research has been funded by the National Institutes of Health. In autumn of 2002, he received a 5-year Career Development Award from the National Institute on Aging. And the award supported his research project on the role of daily spiritual experiences in the disease process. And in 2006, he received the Anton Boyson Professional Service Award from the Association of Professional Chaplains. I'm delighted that he's here today to talk about religion, spirituality and health. We are going to try and make this available in some form afterwards, or whether it's YouTube or some other format, but it is being videoed very kindly. He's agreed for that to be done, so if you do miss any snippets, there'll be a chance to go back. He's going to speak until I think about 12:45, at which point there'll be an opportunity for questions and discussion. Finally, just to say that those of you who are going for the symposium, if you can follow a small crowd down to the Rose Bowl, those of you who don't know Leeds Beckett University, we're going to another building and there are some voucher contributions towards lunch down there. And if we meet in the foyer of the Rose Bowl, I'll be able to hand those out to you. So without further ado, George, delighted you're here. I really look forward to what you're going to be able to say to us today. Thank you.
Thank you, Chris. It's actually my pleasure to be here, to be with you, to have some conversation with you about chaplaincy and research, to learn more about your own engagement in chaplaincy and these subjects. So looking forward to a good afternoon. We may be stuck here.
have we frozen?
It looks like it. There we go.
Okay,
Good,
I think
good.
just check that.
Yep,
Yeah.
fine. So, these are the key points that I hope we'll be covering in this time. That we'll spend a little time on the definitions about religion and spirituality, making sure that we have some sense of distinctions. Talk about the research that is emerging about religious or spiritual needs in different clinical populations, and then talk a little bit about some of the implications of this evidence for more effective use for healthcare chaplains. So we could spend all afternoon on the issues of definition of religion, how that's similar to and distinct from spirituality. These are the definitions from the psychologist of religion in the U.S., whose name is Kenneth Pargament, who's really a leader in psychology of religion and coping. And Ken talks about spirituality as the search for the sacred, and he talks about religion as the larger social institutional context in which that search for the sacred takes place. By the way, I have a sheet with all the references, so in case you want to kind of follow up the details on any of these studies, we can make that available to you by email, so you don't have to write furiously. So part of what I think is interesting when we think about distinguishing religion and spirituality, they have some overlap, they have some differences, is that we then have to think about, if we're going to do research about religion and spirituality, how are we going to measure them? How are we going to measure what's different, what's similar about each of them? And I thought there's just a very interesting variety of measures of religion and spirituality that have been developed. We could look at them, we could discuss the strengths and weaknesses of them. I thought just in terms of measurement, I would show you a measure that I just became aware of several weeks ago. It's an Images of God scale. It was developed by Hanneke van Laarhoven and her colleagues in Amsterdam. And they think about actually, they wanted to not assume that everyone's image of God was a wise old fellow with white hair sitting on a cloud. So some of the images of God are personal. Did I do something? That's fine. Let's do it this way. Some people's images of God are personal. So item 2, for example, would be a personal God. God knows and understands me. Some people's images of God might be non-personal. So number 10 is something higher that unites people with the world. And some people may, when they think about God, say, who God is really unknowable. And that's the most important factor. And so item 13 would be an example of this unknowable God. There's something higher through which the world started and was then left to just go on. And so of those 14 items, they kind of come into this kind of 3 different images of God, and the research using images of God, this particular images of God scale has just begun, but people can score high, low, medium on more than one of these, and it would help us then understand what kind of images of God are people holding, what does that mean for what they expect in terms of God and religious coping in times of illness. So it's as we think about definitions of religion and spirituality, we can think also about trying to measure religion and spirituality, and there's just lots of different ways to measure different parts of religious belief, religious practices, spiritual experiences, relationships. And here's an interesting way to think about God may mean different things to different people, and we might be able to come up with ways to measure those differences, and then think about what those differences are and their implications for different kinds of religious coping with different health contexts. So the bulk of what I want to talk to you about is actually measurement of spiritual need and its prevalence in different clinical contexts. But before we talk about the kind of pain, struggle, need, I do want to remind you something you may well know, and that is there's a robust body of evidence. Much of it comes from the U.S., but not all of it, and we begin to see similar findings in other cultures and contexts about the beneficial effects of religion and spirituality on health. So in terms of the research about religion and health, in some sense, the most well-established finding is that people who have more intensive involvement in religious activities, particularly more frequent involvement in worship, public worship, actually tend to live longer. And so these are a variety of different studies that have looked at this, a whole bunch of them in the United States, but that one actually is in Denmark. There's one actually that's been done in China that I don't have on here. And this one here is actually what's called a meta-analysis. So the estimate of the protective effect of religious involvement on mortality is actually from data from 42 different studies. And so if there was no association between worship attendance and mortality, we would have what's called an adjusted odds ratio of 1, and when it's less than 1, it actually indicates the extent of protection religious involvement. So we see on average about an 18% reduction in the likelihood of mortality over some period that might be 5 years, 7 years, 10 years for those who are more frequent worship attenders compared to those who are less frequent worship attenders. So it's really a remarkable, consistent finding, particularly when you begin to look at the studies that have come from cultures like Denmark and China, where religion expresses itself in very different ways than it does in the U.S. The other thing that's really quite consistent, particularly in the studies in the U.S., is how important religion and spirituality is to people when they cope with serious illness. So these are data from the largest study of cancer survivors. It's a big study conducted by our American Cancer Society. It's approximately 9,000 cancer survivors. About a third of them were 2-year survivors, about a third of them were 5-year survivors, a third of them were 10-year survivors. They come from all over the country. They had 6 different types of cancer. And one of the questions that was part of the survey was, to what extent do you agree with the statement that my faith or spirituality has helped me through my cancer experience? And you'll see on average, actually, more than 2/3 said that religion and spirituality helped them very much or quite a bit. And in the U.S., we have important racial ethnic differences in terms of both generally religious involvement and the importance of religious involvement in coping with illness, and those racial ethnic differences show up in these data as well. So the highest level of endorsement among our African American cancer survivors, also a very high level of endorsement among Hispanic cancer survivors, but also 2/3 of the Caucasian cancer survivors say religion and spirituality is very important as they cope with their cancer experience. And that's a pretty consistent finding whenever we ask that question to cancer patients or others. One of the most important things that helps them cope with the illness is religion and spirituality. Part of what we need to know is to what extent that's true in cultural contexts like the UK or other cultures in Europe. The research is not as extensive, so I wasn't able to unearth anything comparable for the UK experience, unfortunately, on this question. A lot of the research about religion and health, initial research, was done actually with people who had cancer, but we've begun to do research about patients with other kinds of health problems, and an important body of research actually is the role of religion and spirituality in helping people with mental illness, chronic mental illness, cope with mental illness. And what's nice about this study is it's not from the U.S. This is a study from Sylvia Moore and her colleagues in Geneva, Switzerland, who've actually been doing a lot of research about the role of religion and spirituality in coping for people with severe mental illness. In this particular study, they were actually able to compare the Swiss sample to a sample in Quebec, and this is a sample North Carolina in the U.S., which, as you would know, is actually, the U.S. is not all evenly religious. Is that our corners, our northeast corner and our northwest corner, people tend to be less religiously involved there. Our southern part of the states tends to be an area of high levels of religious involvement. So North Carolina is in what we call the Bible Belt of the United States. But take a look actually at the data from Switzerland and Quebec. So when patients with schizophrenia were asked how important religion is to you, it's 0 to 10. How important is it in your daily life? There's pretty high scores, 6.7, 6.5. How much does it help you give meaning to your life? Again, moderately high scores here. How much does it help you cope with your illness? Moderate levels of agreement here. And down here, actually, the data are collected in an interview with a psychiatrist, a 20-minute interview. And after the psychiatrist is done, psychiatrist kind of scores overall to what extent was religion a positive influence in this patient's life, overall to what extent in the clinician, the psychiatrist's opinion, was religion not a helpful part of this patient's life. And you'll see the clinician scoring was that it was a positive part of the life for at least 80% of these patients in Geneva and in Quebec. So cultural context of a little closer to what you might see here in the UK or in Europe, a different kind of clinical context, people with severe chronic mental illness. Religion is an important part of living with that illness. And that's kind of consistent with other evidence that we see, particularly from studies from the US. So three quick studies about the positive associations of religion for health and for coping with illness. Now we'll get into the piece that I think is more important for spiritual caregivers and for other healthcare professionals who want to kind of provide comprehensive care for patients and make good referrals to spiritual caregivers. So these are data from Scott Murray and his colleagues in Scotland who did research with patients with advanced lung cancer and patients with advanced heart disease. And part of why I have this here is both to illustrate spiritual needs that have been found in this research, but to also illustrate that not all the research about religion and health is done with surveys. Important research about religion and health is done in interviews. It's qualitative research where we ask people questions, we listen to their answers, we transcribe the interviews, and then we look for the themes in the answers. And I think as we move forward, both in research about religion and health and in chaplaincy-related research, the qualitative methods are important. So these are data from Murray and his colleagues in Scotland, 20 lung cancer patients. Part of what's very interesting about this study is actually they didn't interview the patients just once. They actually interviewed them every 3 or 4 months for as long as they were alive over the course of a year or so. So that's actually a more sophisticated kind of qualitative research. And so you see, as we begin to explore the notion of spiritual needs here, that the team kind of concluded that among the lung cancer patients, there was despair about illness and death, punctuated by episodes of hope when they were feeling better. And among the heart disease patients, there was really apparently more pervasive hopelessness and isolation associated with chronic illness and the limitations it imposed on their life. And you see some quotes here from the patients. So an important kind of method for examining what patients say their spiritual and religious needs are, which I think is important in terms of guiding other research and guiding our clinical care. So in addition to the qualitative methods where we interview patients and ask them, what would you say your spiritual needs are, how are you coping with your illness, there are other kind of approaches to identifying spiritual need. And this particular study is from the MD Anderson Hospital in the US in Houston, which is one of our premier cancer care centers. And the chaplains there, these are data from care for inpatients in the palliative care unit. Chaplain is well integrated in the inpatient palliative care unit, so the chaplain there sees every inpatient in palliative care and conducts an interview. And in that interview, the chaplain is actually listening for, he's using a spiritual assessment tool that they've developed there, and he's listening for 7 different themes. You can see them here: despair, dread, brokenness, helplessness, guilt, meaninglessness. And based on his listening, he's kind of identifying, is this person experiencing pain or distress at a significant level around that issue? And if so, they kind of get 1 tick. And if they're experiencing pain or distress around 2 issues, they get 2 ticks. And so you'll see for this sample of 113 patients, for half of them, they got no ticks. Based on his assessment interview, he said there's no intense spiritual pain in any of those 7 dimensions. But for the other half, there was some spiritual pain, and for 1 out of 4 patients, there was actually spiritual pain in at least 3 of those areas. So that would be a fairly high level of spiritual pain that certainly would require chaplaincy attention. We see actually that it was most common that the pain was in areas of despair or dread or some sense of brokenness. So part of what I think is interesting about this is it illustrates a method for assessment and identification of spiritual need. It actually it illustrates a method for quantifying spiritual distress or spiritual need. And because it actually quantifies spiritual need, it enables the chaplain in this institution to say to the director of the palliative care unit, you know, 1 out of 4 of our patients are actually experiencing intense levels of spiritual pain. We have to have enough chaplains to be able to address that. So it actually provides what we might call a measure of acuity of spiritual need or prevalence of spiritual need that enables chaplains to have conversations about staffing levels to address that need that we really haven't had until we've begun to do this kind of work. Some of you may know the work of Harvey Chachanoff, a palliative care physician in Winnipeg. Harvey is really one of the world's leading palliative care physicians and palliative care researchers. And among other things, he and his colleagues have developed something called dignity therapy, which is kind of a life review process for palliative care patients to help them kind of maintain dignity at the end of life. And it also leads to the generation of a kind of summary of important things of my life that the patient can give to their loved ones as a kind of legacy. But among the other things that Harvey has done is he's actually developed a personal dignity inventory, and it has about 25 items here. And part of what I like about the personal dignity inventory actually is that I think while he didn't think of it this way as a measurement of spiritual need, I think if you look at the items, a number of the items are about things that many chaplains would say are religious or spiritual issues. So I no longer feel like I'm feeling no longer like I am who I was. So a third of the patients are expressing that need. I'm feeling uncertain about the future. I'm concerned that I'm a burden. I'm worried about the future. I'm feeling unfinished business, 1 out of 5 patients. So I think that if we want to, again, in the palliative care context, think about how to measure spiritual need, how to describe the prevalence of spiritual need, how to describe the need for staffing to address spiritual need. Chachanoff's personal dignity inventory is a possibility here. Part of what I like about this is that the data comes from Canadian patients and Australian patients, and so you don't have that kind of high level of religious involvement that we see in the US. Both Canada and Australia are moving a bit more toward more secular kind of cultures, more similar to the UK. This is one of my favorite pieces of work on measuring spiritual distress. This comes from a team in Lucerne, Switzerland, led by physician Stephanie Monod, and she and her colleagues have actually done a series of papers to try to develop a good measure of spiritual distress for use with geriatric rehabilitation patients. And they came up with a conceptualization of spiritual need among geriatric rehabilitation patients that had 5 different dimensions: a need for a sense of connectedness to transcendence, a need to maintain life balance, that whatever has brought me to rehabilitation has kind of thrown my life off balance. I'm not the person I used to be. To what extent can I regain balance or regain a new balance? To what extent are people suffering from feelings of loss of identity, feelings of loss of control, feelings of loss of respect? So they have 5 different areas in which a chaplain is listening in the interview with the patient, kind of an open-ended, unstructured interview with a newly admitted patient. To what extent am I hearing no spiritual need in that particular area, or a little bit of spiritual need, or moderate levels of need that are beginning to outstrip the person's resources to cope with it, or severe need that's really overwhelming the person's need to cope with it. And depending on where they are in that, they get a score from 0 to 3. And so potential score for spiritual distress, because there's 5 different areas that are scored 0 to 3, is from 0 to 15. And so then these are data from 203 of their patients, and you'll see the distribution of scores. Nobody had a score of 0, nobody's had a score above 11. 2/3 of the patients had some spiritual distress. About 1 in 4 patients had distress in all 5 dimensions. About 1 in 5 patients had severe distress in at least 1 dimension, and the most common area for distress was the need for life balance. So again, a method of assessing spiritual distress, a method of describing the prevalence or acuity of spiritual need in this population that allows chaplains to have conversations with the medical director and say, actually 1 out of 3 of our patients, 2 out of 3 of our patients have some spiritual distress, and 1 out of 5 of our patients have severe distress in at least 1 area. We really, if we're going to do adequate care and not be negligent in the care we're providing for our patients, we have to have enough chaplains to be able to kind of address the spiritual concerns of the patients. Part of what's remarkable about this, I don't have the slide, I didn't bring it for today, is that when you begin to quantify spiritual need based on an interviewer rating, you're entering into the area about, okay, to what extent is this valid and reliable? To what extent does the same interviewer rate the same patient the same way? And to what extent are these ratings that these interviewers are coming up with related to ratings in related areas, measures of related areas in a way that would be consistent, that would give us confidence that there's some validity to what's happening here. And so in another paper, this team has actually published the data about reliability, in which they videotaped the chaplain's interview with the patient. That chaplain rated that patient during the interview. 2 other chaplains watched the video and rated that patient. And 3 months later, the chaplain separately looked at the video again and rated again. And they actually come up with a very similar rating. So that's intra-rater reliability. Same thing that is inter-rater reliability. They had, I think, 20 interviews in which the chaplain did the interview and another chaplain observed the interview, and both of them separately rated the interview, and the ratings were consistent. So the reliability statistics were actually quite striking. I thought that chaplains kind of looking at these things and giving a score from 1 to 3 would not come out with a great deal of consistency, but I've actually become very impressed by this study and would like to see replications of it because it suggests an important method for us. A few more slides on prevalence of spiritual need. These are patients with a different diagnosis in a different cultural context. These are patients from Germany, and the measurement of religious need here is from Arndt Busing's tool called the Spiritual Need Questionnaire. And it looks at, you can actually see the items, or maybe you can't, they're kind of far away, but it kind of, there's a bunch of items and they come into 4 factors: religious needs, needs for inner peace, existential needs, which include meaning, and a need to actually be generative, to be able to help other people. So part of what I think is interesting here is that over 80% of these patients are feeling a need to have inner peace, and a pretty important unmet need here. Another way to think about religious needs: measure spiritual needs and look at the prevalence of different spiritual needs in a different cultural context. Here we are back home. I keep saying this woman's name, Toonie Boyle. I'm sure I'd be glad to be corrected if somebody knows her or pronounce. So she's done a number of different studies along with colleagues, and these are data from 202 women newly diagnosed with breast cancer here in the UK. So part of Ken Pargament's work has been to develop measures of positive and negative religious coping. When there's a stressful event, when I become ill, positive coping is to kind of draw close to God, to seek solace and comfort. Negative coping includes things like feeling abandoned by God, punished by God, wondering why God has allowed this to happen to me. And there's a body of evidence that suggests that people who are feeling higher levels of negative religious coping actually have more emotional distress, they're more anxious and depressed, they have poor quality of life. There's some evidence from some studies that they actually are less likely to recover, and there's one large study in the US that indicated that older adults who had been hospitalized for medical conditions who had higher scores on negative religious coping were less likely to be alive 2 years later. So I thought that was a useful tool for looking at religious coping in the US, but I didn't think it would be very useful in other contexts. But lo and behold, Toonie Boyle and her colleagues find actually that 54% of these women newly diagnosed with breast cancer here in the UK are actually feeling some religious struggle. They're pleading for interventions. They're wondering whether or not God is really caring for them. So positive religious coping, there's over 70%, but negative religious coping is in the 50s. So suggesting that in this sample of women newly diagnosed with breast cancer here in the UK, that there's a moderate amount of spiritual pain. Part of what we don't know is whether or not there are people who are experiencing what Pargament would call spiritual struggle around the time of diagnosis, but a few months later they've actually resolved it. And is there another group that around the time of diagnosis they experience spiritual struggle, but it actually is not going away? And so we might think of that as a transient spiritual struggle for some people that occurs in the context of illness versus a kind of more chronic spiritual struggle for some people. And we need more research actually to help us get some sense of what's the prevalence of the transient struggle. This is clearly a measure around the time of diagnosis. We don't know 3 months later or 6 months later where these women are, how many of them have kind of resolved this on their own or with their families or with their clergy, and how many are kind of stuck in a chronic religious struggle that needs professional attention. So further research is necessary on that, both to get the sense of the prevalence and then also to think about the predictors. What it is about the women who got stuck that's different than the women who were able to resolve it. So we're done with spiritual needs. I'm going to do 3 or 4 or 5 different slides here about implications of all of this for referrals to healthcare chaplaincy and the utilization of healthcare chaplains, and then we'll have time for conversation. These are data from Switzerland. This is actually the same group. I'm sorry, I keep doing that. This is the same group, Stephanie Monon's group, in which they wanted to know what are the factors that are associated with who values a chaplain visit. So they had 300 patients, and they randomly assigned the 300 patients to 3 different groups. One of the groups, no one asked the patients whether or not they wanted to see a chaplain, and 4% of those patients asked for one independently. Another group was independently assigned to a situation in which the nurse said early in the patient's admission, "Would you like the chaplain to stop by?" And a third of those patients said yes. And then the last group of patients was randomly assigned to having a chaplain stop by and say, "Hi, I'm the chaplain on the unit. I was stopping by to say hello. Would you like me to sit down and have a visit with you?" And you see almost all of those patients said yes. And when they did the kind of statistical analysis of what are the factors that was associated with the likelihood of saying, yes, I'd like a chaplain versus no, I don't, who asked is certainly a factor, the chaplain. When the chaplain kind of offered the invitation, there was a greater likelihood of saying, yeah, please sit down. Patients who were more religious, who were older, and who actually were describing their health as poor were more likely to ask for chaplain visit. We've done a similar study, not quite this randomization here, but we actually went to 200 medical surgical patients and asked them, would you like a chaplain to visit? And we found that the more religious patients said yes, the older patients said yes, and there was no association with a kind of physical health condition. So a little bit of inconsistency here, and it'd be interesting to do further research about that. These are data from Israel. Israel is just beginning to have healthcare chaplaincy as we know it. And they have a very strong commitment to actually doing research about the work that they're doing. And these are data from a chaplain there named Mike Schultz. Part of what they're looking at is oncology outpatients. How open would you be to a spiritual caregiver visit? I have to read this one here. Definitely interested, 25%, that's the purple group, right? Possibly interested, 16%, not really sure, another quarter, and not at all open, a third, right? So I think very interesting finding. And then what are the factors that were associated with saying yes, they were interested, being very spiritual or somewhat spiritual compared to not spiritual at all, being very religious or traditional compared to secular, and prior experience with a spiritual caregiver was important. So these are odds ratios. There's over a 3 times greater likelihood, almost a 4 times greater likelihood of saying yes, I would like to have a spiritual caregiver visit if people knew what they were, knew who a spiritual caregiver was, had a prior experience. It's a new thing in Israel, probably in the we have some research in the U.S. that suggests when a nurse says to a patient in one of our hospitals, would you like a chaplain to visit? Patients have no idea who chaplains are. They think they're clergy from the local congregation for the most part. So I think this is a great bit of research here. So we've looked at the research about spiritual need. We have some sense that in different populations there may be spiritual need of greater or lesser acuity in 1 out of 5, 1 out of 4, 1 out of 2 patients. So what are the implications of that for how we organize healthcare and we get the chaplains to the bedsides of those patients who are most likely to need them? So that's led us to think that we need some kind of screening tool that our healthcare colleagues can use to identify patients who may be experiencing spiritual distress or spiritual pain and make referrals to us. We know that in the U.S. context, as I just said, having a nurse say to the patient, would you like a chaplain to visit, is actually not necessarily a good way to get the patients who are experiencing the most spiritual pain referred to the chaplains. We also know, as Adam told me as he was driving in, you have 8 full-time equivalent chaplains here for 2,000 beds, so there's no way that a chaplain is seeing every newly admitted patient. So how do the staff know who are the patients that need to be referred to the chaplains most as highest priority? So that's what we call spiritual screening, and we're in the early days of developing good methods for spiritual screening. This is a tool my colleague Jay Risk and I developed at our medical center a few years ago. that was designed to do this spiritual screening work. It was designed to be simple questions, brief questions that could be asked by a non-chaplain healthcare colleague to a newly admitted patient, inpatient or clinic patient, that could potentially identify who's experiencing spiritual pain or spiritual struggle. So you can't read it, kind of small type, but the first question is religion or spirituality important to you as you cope with your illness? And if the patient says yes, the follow-up question is, how much strength and comfort would you say you're getting from religion and spirituality right now? Would you say you're getting all that you need, somewhat less than you need, or none at all? If the patient says, I'm getting all that I need, we don't think that there's any spiritual struggle there, but we do ask them, would you like a chaplain to visit? But if the patient says, well, I'm getting somewhat less than I need, or I'm not getting any at all, that's the first red flag for potential religious struggle, and we encourage the doctor or nurse or whoever's asking the question to make a referral to the chaplain to stop in and visit that patient and do a more in-depth spiritual assessment to see whether or not there's actually is spiritual need and if the chaplain can be helpful. But the second pathway is in some ways more important. Is religion or spirituality important to you as you cope with your illness? If the patient says no, we don't want to assume that they're happy, well-adjusted atheists. We know that some people for whom religion, spirit, who answer no to the question, is religion, spirituality important to you, are actually people who are alienated from religion. They've been hurt by religion. They've been disappointed by God. And so the task is in some sense to find the right simple questions that can be asked by a non-chaplain healthcare colleague that will flag those folks and enable us to follow them up. So in this version we kind of came up with a question, well, it's not important now. Has there ever been a time when it was important to you? If the patient says yes, then we think that's a second red flag. We do want the chaplain to stop in and say, I'm the chaplain here, I'd like to get to know you, see if there's any way I can be of help. But to see, okay, did something happen between the yes of the past and the no of the present that's actually associated with unresolved pain that the chaplain can be helpful with? So we developed this using medical rehabilitation patients. The psychologists see all the medical rehabilitation patients on that unit, and when the psychologists used it, they found 12 patients who screened positive for potential religious or spiritual distress, and when the chaplain followed up, he assessed that 11 of those 12 in fact did have religious and spiritual distress that required his attention. So that's a pretty good kind of sensitivity, specificity, but it needs a lot more work to be validated. These are just some proportions where it was used with older adults who were being seen in outpatient clinics who were also depressed. Religion or spirituality important to you? This is the US, 82% said yes. 18 said no. How much strength and comfort are you getting from your religion right now? 40% said all that I need. 42% screened positive on that side. And then it's not important now. Was it ever in the past? Yes, 9% there. So we had about 1 out of 2 patients who screened positive in this particular study. Another approach to spiritual screening comes from the work of Karen Steinhauser and her colleagues at Duke Medical Center, in which she just asks the question, are you at peace? These are data from about 1,500 bone marrow transplant survivors. The data was collected at one of our major bone marrow transplant programs in Seattle, Washington. So again, it's one of our less religious parts of the United States. The people who are answering this question are a little bit more like the people in the UK, I think. And you'll see about 5 or 6% are not at peace at all. Another 15%, some peace, but some inner distress, and then a whole bunch, 70% or more, are feeling quite a bit of peace. And here we're mapping the peace answers to scores on Ken Pargman's 7 negative religious coping questions. And part of what you see is that this is doing a pretty good job of actually finding people who are scoring. 70% of the people who say not at all or a little bit are actually scoring positive on Pargman's negative religious coping. So there's some early indication this may have potential as a screening question, and we need further research to check it out. The last screening question is this one right here. Are you experiencing spiritual pain right now? And when the person, healthcare person, asks that question to the patient, they followed up by saying, by spiritual pain, I mean pain that's deep inside of you that's not physical. And when they used that in a hospice in New York City with 57 patients with advanced cancer, 61% said yes. This is our MD Anderson Cancer Center again, but these are actually a little bit healthier patients. They're palliative care outpatients, 91, 44% said yes. So another way to screen, another way to get the measure of potential prevalence. This is not a screening model, this is more of a history-taking model that's based actually on Christina Puhalski's FICA model that some of you may be familiar with. Christina is a physician in the United States who's very interested in the area. And this is actually a German translation of the FICA, and you'll see the items here. Would you describe yourself as being religious or spiritual? What's the place of spirituality in your life? Are you integrated into a religious or spiritual community? What does that mean in terms of how you would like your physicians or nurses or healthcare team to address your spirituality? And part of what we see here in this sample of German patients is that patients did not object to the questions. The vast majority, kind of on a scale from 0 to 10, was it helpful, not helpful? I think this is actually both the patients and the physicians. The patients and physicians found it helpful. A few found it distressing. So we'd have to understand them better and try to find a way to do this without distressing them. And then, based on these questions, the physicians were asked how important spirituality is in this patient's life, and the patients were also asked kind of separately, how important is religion and spirituality in your life? And the physicians actually were pretty much able to map how important spirituality was in patients' life using those questions. So it does suggest that we have some possibilities here for spiritual history taking. All of this is to say that the field of research about chaplaincy is alive and well and growing. Some of you may know, these are two important reviews of chaplaincy research. Some of you may know the work of Harriet Moat and her colleagues. I think it's about 2008 or 2009. It's really the first review. Dr. Moat's from Scotland, and she focused this review on the research that primarily was done in the UK, although she included US research, and it's just an excellent summary. But then in 2011, a team in New York City at the Healthcare Chaplaincy did another summary. And both of these are available free online for downloads for those of you who want to become familiar with it. And the URLs are in the reference list that we have. So, in order to understand what chaplains do, we think it's important actually to get a thick description of chaplains' activities. And so that's why Steve Nolan and I got into encouraging chaplains to write case studies and put together a book of chaplain case studies. We think they have an important role in research about chaplaincy, but also chaplaincy education and education of non-chaplain healthcare colleagues about who we are and what we do. So the book has 9 case studies, 2 from the UK, 1 from Canada, 1 from Israel, 5 from the US, 3 pediatric, 3 psychiatric, 3 palliative care. It also has critical commentary on the cases by non-chaplain healthcare colleagues as well as chaplains with expertise in each of those areas. So it came out a month ago, and as Steve said, it's $18.99. We hope you find it helpful. What happens as we move ahead in this field? So many of you will know the work of Lucy Selman and her colleagues at the Cecily Saunders Institute in London. And part of what they did was actually do a survey of palliative care practitioners, primarily in Europe, but some come from around the world, and asked them, there were physicians, nurses, chaplains, and others, and they asked them, what are the important research needs around spiritual care and palliative care? And you'll see what that team came up with. Kind of moving ahead on these screening tools in palliative care is an important area here, and in determining the prevalence of spiritual distress. As you've seen, there is some research in that area, but it's really still early days. We have to kind of move ahead with all of that. And I've left 10 minutes for questions. What do you think? Thank you. Glad for your comments or questions. We're videoing this, so you want to speak up if you have a question. Please.
Thank you, that was really, really interesting. I work in mental health. I work in mental health, and one of the issues that
That's not helping.
No, sorry, I don't know quite what what the problem is with
Maybe
that.
we'll just answer this.
Perhaps if you repeat the question.
Yes, that would be good.
Yeah, so in mental health, one of the issues that we have is that a lot of nursing staff don't feel confident in asking patients about spirituality. So although we're supposed to, on assessment, ask questions like, do you want to see a chaplain, do you have spiritual needs, the vast majority of cases that question is not asked, it gets left out. I was wondering if you'd found that having things like the screening tool was actually helping nurses feel more confident in those questions, or whether it's not actually an issue in the places where you've been doing your research.
No, it's very much an issue in the States, and quite the same issue. Nurses and physicians, when you ask them to what extent they're willing to kind of integrate some kind of spiritual screening or spiritual history taking, they're for the most part reluctant to do it. Sometimes they say, I don't have enough time, but a big piece of it is I don't have the training to do it. And so where it's been successful, it's because there has been fairly intensive training and retraining. So it's not a small amount of education, commitment to educating the staff to make it work, to kind of role play some scenarios where the worst fantasy of the nurse kind of gets put into the role play, and they see that no one dies, when these things get said. Now that we're beginning to think about the importance of screening and then develop screening tools and then inviting our healthcare colleagues to use them, we're going to need a lot of education to get that implemented.
Thank you.
Please.
Just following on from that, I've worked for many years as a surgeon in oncology, knowing that over the subsequent 5 years, 50% of my patients would die from their disease. And over the past few years, quality of life has been my interest for many years. I've been working with a European group to try to develop a spiritual well-being measure, and we're currently doing the statistical analysis on it. But anecdotally, we found in terms of health professionals that those of us with personal faith have really backed this as an area of research, and in our own clinical lives are, I think, far more likely to have this conversation. And I just wonder whether that was your experience, and whether that is possibly a way to get clinical champions of spiritual measurement.
Right. Just in case it didn't get picked up on the audio, you've been working as a surgeon with cancer patients and now developing a tool that clinicians can use with patients. And you're finding that the people who are most eager to use the tool are people who are personally people of faith. And that there's actually a moderate body of research that shows that that's exactly what happens. That physicians, nurses, and other healthcare professionals who, for whom faith is important in their own personal lives, are more comfortable integrating it into their professional practice. And so your thought is, well, perhaps those people can become champions to kind of help their healthcare colleagues also move in this direction. And there may be a plus and a minus to that, because their more secular colleagues may look at them and say, oh, well, we always knew they were like that anyway. So the issue is, can you find a more secular champion who would actually perhaps have a different kind of credibility, or maybe one of each. Yeah, good luck in your work. Yeah, Mark. Yeah.
You've touched on quite a number of tools and scales, and there's a kind of growing library full of these things. When I talk to other health professionals, it doesn't take long for them to say, well, of course we have our golden standards, physio, Bartel, if we want depression, has PHQ-9, we kind of know what we're doing. Is it time that chaplains got their act together and made some consensus on which are the scales that we should all be using?
Right. So to repeat for the audio, Mark Cobb is asking, there are gold standard measures of different kind of clinical syndromes in different contexts, that there are gold standard measures for example, in depression, the PHQ-9, and is it time for chaplains to kind of move past this diversity of different tools that I introduced today to kind of develop a consensus about our gold standard. And so the question I would put was, how would we develop that consensus? And my answer, because I'm a research guy, is that we develop the consensus around the tools that actually have the best clinometrics is the technical word for it. They have the best validity, reliability, and evidence of clinical usefulness. And we have almost no tools where any of that testing has been done. So that's part of why I say it's early days, that we actually need to do that kind of research on the best candidate tools, so that we then make the selection based on the best evidence. But meanwhile, we have to go on. I think the best thing is to kind of say, okay, in the hierarchy of evidence, professional expertise is evidence. Happens to be the lowest level, but it's evidence. So, if in our professional opinion, the spiritual distress assessment tool from Switzerland looks like it's the winner, let's use it until somebody comes along with the research to say that something's better. So just because we don't have the evidence to be kind of definitively answer the question about clinometrics doesn't mean we don't have some hunches about which ones are going to be useful for now while we're waiting for that evidence to come along. Please.
One more. I think we probably need to.
Yes, there you go.
I'm a chaplain in a mental health hospital. And the problem we face is that even when we have evidence, as you mentioned, that religion and spirituality have impact on healthcare, but with our clinical colleagues, the problem we have is how do you quantify that impact when the carers, the clinical carers, and then the chaplain are making some input, although the input we make is there. But the question is, how do you quantify the input you have made in terms of outcome for the patient? I don't know how you have looked at that problem.
Yeah. So for the audio, just to kind of say, how do we quantify the chaplain's contribution to the care for the patient?
In terms of outcome.
In terms of outcome, and this is a word I want to underscore because in the United States, we're very much interested in something we call outcome-oriented chaplaincy. Chaplains are mostly trained in the language of process, and that is being present and empathic with people, offering support and hospitality. But what's the difference the chaplain's care makes in a measurable and important clinical or spiritual outcome for the patient? And we haven't been able to do that until now. And so our colleagues who are used to their care being measured in terms of outcome are expecting that we actually will be able to kind of describe outcomes for our care. And because we haven't had quantifiable ways to describe the spiritual need, we haven't been able to kind of say, this patient in medical rehab was feeling like her life was completely undone because of the stroke, and that she wasn't who she was at all, and she was experiencing intense spiritual pain kind of at a level of 9 or 10. And the chaplain worked with this patient for 2 weeks and enabled her to talk about her sense of loss and grief, and enabled her to think about, well, I didn't lose everything. There were some things that were still important to me, and I am a person of faith and still have a sense that God abides with me even though my life has changed. And 2 weeks later, we measured spiritual distress again, and we discovered the patient's spiritual distress was 3. Right? So it's gone from 10 to 3 as a result of 2 weeks of chaplaincy care. We've never had the ability to do that because we haven't had quantifiable methods for kind of describing spiritual distress, but we're beginning to move in that direction, so that enables us to begin to think about outcome-oriented spiritual care. We're moving toward it, but it's early days, and we need a lot more research and a lot more money to do the research.
Yes, it's all going to go for book sales. Thank you. I mean, it leaves us at a very good point, I think, in terms of those of you who are able to join us for the symposium this afternoon. I mean, part of the difficulty, I think, with that area of research, is you can show that benefit after 2 weeks. Can you pin it to the chaplain? Is that the key ingredient, or is it normal progression in response, and all those sorts of things that make the complexity of our contacts and interventions so difficult in a way to badge up that benefit for chaplaincy uniquely, and it's a really big challenge for us all.
Yes.
George, thank you so much for giving the lecture today and for all that input, and I'm glad it's going to be available. Thank you also for those who provided the IT support for today in terms of capturing that on video to make it more widely available. I hope that those of you who've been here have enjoyed and found useful and thought-provoking what George has shared with us today. As I say, those of you who are coming on for the symposium, there's a break now. I think in reality we're probably going to start at 1:45. But if you can make your way down to the Rose Bowl, if you don't know where it is, find somebody who does know where it is. And if you get completely lost, 1:45, room 322. Thank you, George. If anybody wants the reading list, just email me and I'll make that available to you, all the references which George was talking about.